Good afternoon and welcome to our educational webinar, A Patient's Journey and the Value of a Sleep Coach. My name is Rachel Bohr and I'm EnsoData's Director of Marketing. We appreciate you taking time out of your busy schedules to be with us today. And now I would like to introduce you to Lacey. Lacey Adams is a sleep coach with EnsoData. She is board certified educator, certified in clinical sleep health. Lacey has over 8 years of experience as a registered polysomnographic technologist, specializing in diagnostic sleep testing, along with treatment and management of sleep apnea, as well as other sleep disorders. Lacey started out as a night technologist and transitioned to utilize her CCSH as a day tech, helping patients with PAP acclimation, compliance, and sleep-related issues. Later, she became a sleep lab director, assisting in building a state-of-the-art sleep lab within a wellness center. Today, Lacey uses her experience to provide coaching and guidance to people adjusting to PAP therapy. She enjoys encouraging people in healthy sleep habits and developing a positive mindset for both sleep and overall wellness. And with that, I'm going to hand the presentation over to Lacey.
Thank you, Rachel. Hey, everybody. Thank you so much for being a part of this afternoon with me. I know our schedules are so busy, so it's special for me that you're able to join me today. So I hope to provide you some good material that's encouraging and educational all at the same time. So obviously my topic is a sleep patient's journey and the value of a sleep coach. The sleep coach is more of a newer term, but a lot of my passion behind this specific role and why I feel like it's important has a lot to do with the physicians that I learned under when I first started. So before I get into this presentation, I want to just take a second to honor I like to call them teaching physicians, but the physicians that I had a chance to learn under, because I feel like the longer I've gotten into my career, the more valuable and thankful I am for that time I had with them. So I had learned under some really good physicians, but two specifically that I want to just honor their legacy. One was a pulmonologist. He actually passed away when I was a night tech, but he was a pulmonologist and he loved sleep. And I dedicate a lot of my passion to learning underneath him. The other was a neurologist, and they made a great team in teaching all of us techs that learned under them, and I'm so grateful. The neurologist is beyond the age of retirement, but still actively caring for patients, and he's the medical director of a sleep lab in a hospital back in my hometown. So I just want to honor them because I wouldn't be where I am today had they not invested and mentored me and the team that I worked with in the beginning. They would come in the mornings at like 6:30 before they would make their rounds in the hospital, and all of us sleep techs would prepare our paper chart right in front of the reading station. We would have the sleep studies from the night before pulled up, and each of us would take turns going over these studies. We would stand next to them as they looked at the staging and the scoring and played the running view as they reviewed the studies. We were kind of trained from an early point in our career to prepare a case study for them with each patient that came in. So in that incredible amount of time that we had to spend time with them, with the patient, we were able to develop like details. This is a 50-year-old patient. She has this many children. These are her complaints. This is why she's here. And so when the doctor would come in, we would prep the doctor with this patient's story as he's looking at their study. And then our doctors would actually go in the room and see the patient, talk about them, go over results. And so we got the chance to be a part of that interaction. And I feel like we were able to be a liaison, preparing the doctor for the patient communication, and then also before the doctor came in, preparing the patient with a chance to know what the sleep study was looking at, what an AHI is, what sleep apnea is. So a variety of just preparation for that communication, so it made that patient-doctor conversation just as optimal and successful as it could be. So I'm gonna move forward. I'm acknowledging conflict of interest. I'm not talking about any of EnsoData's products today, but I am acknowledging I do work for EnsoData. I just get to talk about something that I love. So learning objectives today. What is a sleep coach? How do patients benefit from having a sleep coach? And then how does the sleep coach add value to both the sleep physician and the rest of the sleep care team? I do want to read a poem to all of you. You can read along with me. This is from the perspective of somebody struggling with sleep. I close my eyes and try to rest, but sleep won't come. I'm so distressed. Tossing, turning, hours go by, and morning light begins to pry. It's like a curse, this lack of sleep, no matter what I do or keep. No pills or teas or soothing balm can bring the sweet relief of calm. I feel like giving up the fight and facing each day's endless plight. For sleep, it seems, is just a dream, a myth, a lie, a hopeless scheme. But then I see a glimmer bright, a spark of hope, a guiding light. For sleep coaching is now my aid, a path to rest that's been remade. With expert guidance, skill, and care, my sleep can heal and bloom and dare to show me that a night's embrace can bring me joy and peace and grace. So I'd like to say that I wrote this all by myself, but I didn't. I'm not skilled in poetry. It's not an art that I've actually studied or practiced. I really admire people who are gifted in this area because it's not something that comes naturally to me. But I did, with the help of AI, ChatGPT specifically. I know it's been a big talk here lately. I was able to create something beautiful that I otherwise wouldn't have been able to do on my own. What I love the most about this is that the sleep coach comes in as a spark of hope and a guiding light in a hopeless situation. So sleep coaching. I'd mention AI and ChatGPT because technology in this age in general, but specifically in the sleep technology world, it's advancing rapidly. It's happening really fast and it's exciting. There's a lot of good things that are coming with it, but there's also a lot of fear associated with this growth. So fear by definition is an unpleasant emotion caused by the belief that someone or something is dangerous, likely to cause pain or threat. What I believe about fear is that it comes from a lack of understanding, the unknown, uncertainty. So this can be both from a sleep technologist's perspective. I think that there's a lot of fear associated with what the future of our role holds. Starting in running sleep studies myself, that's where my passion is. There's growth in the home sleep studies, and there's growth in even more spaces in our field. So there is a lot of fear. But also from the patient's perspective, the unknown of starting this new journey with CPAP therapy or just being given this diagnosis and not understanding a lot about it, there is a lot of fear. So what's important to me is to both bring hope to sleep technologists in that people need people. Yes, technology is great, and just like ChatGPT helped me write that poem, it was my idea to create this poem and to start to create something beautiful. So we as clinicians, we as humans, it's important for us to care for people and use technology to help us and to not look at it as a threat, but more of an asset to being able to take care of patients even better. The CDC has called insufficient sleep a public health epidemic. The current patient journey is fragmented, and so how can sleep coaches, how can we use technology or growth or whatever that may be to fill this gap in the patient's journey? So our main focus is on diagnosis, and for a good reason. So I know a lot of these statistics aren't new to a lot of people looking, but around 50 to 70 million of adults are living with a sleep disorder. 30 million of those people have sleep apnea specifically. It's estimated that 22 million Americans have moderate to severe sleep apnea. And then only 6 million of those people are actually diagnosed with the condition. So I know there's, with again this growth of technology, we're learning a lot more. There's a lot more data coming out. So some of these numbers are, I think, our eyes are being opened, and there may even be more. I think, Robert, if you haven't seen the most recent webinar before this, Robert Miller was talking about sleep navigators, and that was a really good topic. So you can go back and look at that and watch that if you haven't seen it. But he even acknowledged there's research saying about 90% of people are undiagnosed. So there's just a lot of people who have a lot of sleep problems who need a lot of help. But my question is, why give somebody a diagnosis with no game plan to make sure that they are successful in treating this problem? So I want to encourage us that the focus on outcomes is really just as important. As we all know, CPAP is gold standard. Like, it's usually the primary treatment, really, for sleep apnea. But despite its effectiveness, people aren't benefiting from it because they're not adhering to this treatment. They're not using it. These statistics are showing that 8 to 15% of people refuse treatment after their first night of using it. And then 50%, at least 50% of individuals continue its usage within, or discontinue its usage within 1 year. So they stop using completely. Adherence in general varies from 17 to 71%. The specific study that I found was focusing on more like age and sex and how that causes this variation. But really, these are statistics we're looking at. Behind these statistics are people. Like, these are human beings with their own stories, their own struggles, their own hurdles in life, their own motivators, their own reasons for even having a sleep study to begin with. I was working with a patient just the other day who I had not been able to get in touch with for like 2 to 3 weeks after they had been set up. By the time I had a conversation with him, our conversation was he acknowledged that he was taking care of a wife who was like dying of cancer, and his health was on the back burner because he was focused on her. He was focused on taking care of her. And so there's a lot going on. His children wanted him to have the sleep study so that he could monitor his health and he could be around, one, to help take care of her as long as she's here, and then two, to be around and be present for them. So people's motivators of why they're even pursuing treatment is different. And then the same reason why people aren't adhering to their PAP is there's just different things going on in their life. People need people. There's limited support during this 4 to 8 weeks of adjustment. And then if people aren't able to tolerate CPAP specifically, a lot of times they just give up. They don't ever follow up with the doctor. They don't ever pursue other options. So the sleep coach is able to step in and provide support in this really critical time period, but also provide education with with other options. So what is a sleep coach? I kind of touched on that just a little bit. But when I think about a sleep coach, I like to think about what is a coach? Coaches for me that were involved in sports that I did. There are coaches that are involved in coaching people in life in general, as well as business coaches. I like to think of inspirational coaches from movies like Mr. Miyagi and the Karate Kid and Remember the Titans, and the way those coaches made a huge impact on those teams. And then being from Alabama, I'd be remiss not to mention this coach right here. I think about coaches who zoom out. They zoom out from whatever is happening, this game. They are on the sideline and equipped with tools in their tool belt to guide, encourage, inspire, teach, step alongside this team or this individual, meet them where they're at, and bring them toward a desired end goal, a victory of some sort, a win, some type of success. So I think about a sleep coach doing the same thing. A sleep coach is somebody who is aware and experienced in the intricacies of sleep health, sleep disorders, sleep apnea, and the treatment of sleep apnea or different treatment options. And then they're equipped with these tools in their tool belt. They're able to step alongside this individual, link arms with them, and help guide them toward success, a desired end goal, victory, a win. So there are different types of sleep coaches. There are sleep coaches in a non-clinical setting. I think a lot about sleep training for babies. And then there are sleep coaches who work with athletes or business executives to optimize their performance. There's actually another really good webinar. Drew and Teresa with Sleep Better NYC, they did sleep coaching in more of a non-clinical setting, a webinar sometime last year. So if you haven't seen that one, go back and watch that one as well. It's good. But for the rest of this conversation, I'm going to talk about sleep coaching in a clinical setting. So that's more of a durable medical equipment type setting, as well as a sleep center or a sleep clinic, where you're mainly focusing on therapy adherence, CPAP adherence, or compliance, or what that looks like after the person's been diagnosed and prescribed a specific sleep disorder. So adherence, I'm sure majority of you that are watching this know what I'm about to say, and I've heard it over and over again, but I know as a sleep tech, I was running the patient study and I knew I was telling them, hey, you're going to follow up with your sleep doctor in 31 to 90 days, and you'll be able to troubleshoot issues, and that's a chance for you to interact with the doctor. But I didn't fully understand until later in my career that this is a cut point, and insurance, they're not going to want to pay for something that's not being used. So, I mean, that makes sense. But at the same time, this can be a really intimidating thing for patients. They have to use their machine for at least 4 hours for 4 hours a night, like 4 hours or greater, and then for 70% of the night. So if you think about in a 30-day time period, they want you to wear your machine for 21 days in that 30-day consecutive time period for at least 4 hours. And so sometimes this gives people an incentive. It helps people have a goal and gives them a chance to try to meet that. But in an already stressful adjustment period, that can cause a lot of anxiousness and worry. A lot of patients are just more concerned with, am I going to get my machine taken away, or I might as well give it back. I don't know if I'm close. So sometimes just having a sleep coach along the way to acknowledge, hey, this is where we're at, you're doing a great job, or we've got to push this forward a little bit more, is important. Because when people don't meet this criteria, they either have to return their device, or they have to self-pay for it, or they have to go through the process all over again. So when I think about the current patient journey without a sleep coach, they've got this long drawn out journey, which looks different in every practice. Sometimes it takes a really long time to see the sleep doctor. Y'all know what this looks like. But they have the sleep study, they get their equipment, and then they've got this gap between where they have their equipment and when they see the doctor. Sometimes they may not even put the mask on. They may not use it at all. Maybe they're like the earlier percentage that uses it one night and never puts it back on. Maybe they try to use it, they think they're doing great, but there are a lot of issues along the way that if they could have been addressed by somebody just supporting them along the process, or people who just have issues in general that maybe give up halfway through. If they had support somewhere along the ride, that would have looked differently for them. So I'm going to go into this patient case. I'm going to talk about Linda and her story today. So she's 43 years old. She had complaints of snoring, wheezing, witness apnea, and excessive daytime sleepiness with an Epworth scale of 15. She was diagnosed with severe sleep apnea with obvious, significant drops in her oxygen saturation. She was prescribed CPAP, and she has Medicare insurance. So she feels like she is doing great. She's seeing improvement in her alertness. There's resolve, or her pitting edema is being resolved. She's seeing some weight loss. Her residual AHI is at 0.8 from that original 46. She's using her machine in the last 30 nights, 27 out of 30 nights. So she feels like she's doing a really good job. That's 90%, right? However, she's only been using her machine for 3 hours, 57 minutes, and 39 seconds on average. When we were talking about just a minute ago with the adherence model for CMS, that needed to be 4. So had she been using her machine for 2 minutes and 29 seconds more, she would have been considered compliant. However, her DME company reached out to her, and her insurance company was requiring her to return the machine. And in order for her to have treatment again, she would have to be requalified only after having another sleep study, issuing another CPAP device, waiting for authorization. This specific scenario I actually got from an article with the Journal of Clinical Sleep Medicine, and they just acknowledged this shouldn't be something that any physician should have to deal with, any patient should have to deal with, because it's just dangerous. Had she had a support system in the middle of that process to just say, hey, you're doing a really great job, but let's bump that usage up just a little bit. What can we do to get you using it for closer to 4 hours? This may have completely been avoided, and she would have not had the issue to begin with. When I think about a patient's journey with a sleep coach, I think about, if you can imagine, let's compare. You have a patient come in and they are anxious and they are nervous, and you are working through the mask fit, you're working through all these different issues that they're running into. You finally get to a point where they're doing okay, they've got their wires on, they've got their things are starting to smooth out. Can you imagine being able to tell that person, hey, I'm here to get you through tonight, but we have a sleep coach on board. We've got somebody on our team that they're going to pick right back up once you have your sleep study. We've got somebody to follow you. We've got somebody to support you, somebody to step in and help educate between sleep physician and DME to go over those diagnostic numbers, to step in between DME and that period of time that they see the sleep doctor to help troubleshoot with a mask leak. Go through comfort settings like the humidifier. If the pressure feels like they can't tolerate it, you have somebody to communicate with the doctor. And then if your practice allows you to, maybe even follow up after they have that 90-day face-to-face with the doctor. Check in at 6 months, check in at a year, and really follow that patient. I can't help but think about a specific patient that I reviewed a study for when I was a day tech. I wish I had this hypnogram to go over with you. When you think about some of the most severe patients you have treated, you have cared for, whether you're a doctor or a sleep tech, I want you to picture this patient coming in for their sleep study and starting to doze off. And you're sitting behind the screen as a sleep tech, and you're seeing they're falling asleep, but then you can start to see those apneas start to happen. And those are literally absence of breathing for 30 plus seconds. And then you start to see the oxygen levels drop lower and lower down into the 60s, and you know, okay, this is a split study. We're going to get a CPAP on this person. Let's do this as soon as we're able. Fast forward, end of the night, you've got that patient titrated on a CPAP of 15. You're seeing them REM supine. You're seeing their breathing beautifully adjust. You are seeing oxygen levels even out, just steady, 96, 97, 95. You're seeing just a beautiful transition. This person is arms above their head, REM supine, CPAP surrender, and they're titrated, and it's beautiful. And they wake up the next morning and they tell you they've not slept that well in a long time. But imagine they go home and they don't have support. They get a week into using the CPAP and they just give up because they get overwhelmed. As the person caring for that patient, how discouraging and heartbreaking is it to know that all that time and that effort to know that if that patient used that machine, their life is going to be different. So when you have a sleep coach come in, they have times where they can jump in this patient's journey and they can intervene and they can support and they can lend a hand. It can completely change somebody's outcome. So a day in the life of a sleep coach, you have typically, for me, I'll use the CCSH credential and I get a chance to meet one-on-one with patients, and the coaches provide encouragement, they provide education, they communicate not just with the patient but also their caretakers if that's needed. Just a variety of support. I mentioned the CCSH credential. I know I mentioned Robert earlier. He mentioned that too in his Navigator webinar. But sleep coaching right now is kind of unregulated, and so what I like to focus on is this clinical sleep educator credential, where you have equipped yourself with the right tools to monitor people in this vital time period of their adjustment to treatment. The CCSH, we coordinate and we manage, we improve, we advocate, and we educate patients. It's a very just intentional credential. So I'm sure a lot of you either have this credential or you wonder if you can have this. There are several different pathways. The BRPT goes into a lot of detail, but there's 3 specific pathways right now. You can get the CCSH by being an active RPSGT, and there's details that go into that. You can have a healthcare credential, whether it's a nurse practitioner, a nurse, dental hygienist, respiratory therapist. There's a list of healthcare credentials, but you can use that as a pathway. And then there's clinical experience for people who have a bachelor's degree or above but don't have a healthcare credential. You can have experience in a sleep clinic. You can work your way to qualifying to sit for the CCSH exam as well. So patient education, it's key. I know people hear that all the time, but it's important to educate the patient from scheduling. If the scheduler is able to say, hey, this is what this sleep study is going to look like, whether it's a home sleep study or an in-lab sleep study. But as you get further down the line, what I like to point out are respiratory therapists and RPSGTs. These people are uniquely equipped. They have this understanding of all the little critical intricacies of this patient's journey. They can make critical interventions. They're equipped with these tools in their belt, like I mentioned earlier. We all play a role in patient education. It starts, first experiences make a huge difference. We all can make this process work, but the sleep coach just jumps in these very pivotal moments. So beyond testing, it's not enough to simply prescribe CPAP and consider that person treated. Adherence monitoring done by a credentialed professional is so valuable because they can step in when they see issues with a leak or issues with an AHI. They provide support in this pathway to success. So who benefits from a sleep coach? I like to say everybody does, but I'll go into a little bit more detail. The benefits for the patient. If you put yourself in a patient's shoes, they're being given this diagnosis. They're told, you're not breathing when you're sleeping. Here's this machine that's supposed to help. Also, here's this deadline. And sometimes that can be kind of like drinking through a fire hose. And they don't sometimes have questions until they get home, or they actually start to use their machine, or they try to touch things. A lot of times our patients are elderly and they don't know how to work the technical pieces of these awesome machines that are improving as we go. But the sleep coach provides the safe place for the patient to reach out and say, hey, I know that my sleep doctor went over these numbers, but I don't know what they mean. The sleep coach gets a chance to step in and talk through those numbers and talk through the doctor's diagnosis and explain and educate and provide that support. They're able to motivate. If somebody gets discouraged and they're just down on believing that this is helping them, the sleep coach gets a chance to step in and motivate and goal set, remind, like, why did you have the sleep study to begin with? Why did you start this process? What were your complaints? And help create this vision of what you can see once you get past some of these adjustment time periods. And the result is overall improved quality of life. Like, that's the goal, right? We all just want to feel better. We want to have a good quality of life. We want our patients to sleep better. Same thing. If they can't tolerate CPAP, they need to be educated on what other options may be. Benefits for the sleep physician. So this statistic, you've got about one sleep doctor to every 44,000 Americans. Like, that's a lot of people who need a lot of help. We love our doctors. We value our doctors, but our doctors have families. They have life outside of work. That's where we get a chance to step in, and we get to be this support system. We get to create this network of empowerment for our doctors. So that way, just like I described earlier, like my sleep mentors early on empowered me to empower the patient so that it made their conversations more effective. We just can create this team effort where our doctors feel supported and they get to focus on seeing more patients, interpreting the sleep studies, prescribing medication, follow-up, clinic visits, like whatever that may be, where we as sleep coaches get to do some of that busy work and take that off of their plate. It's a significant amount of patients that aren't going away. Based on those statistics earlier, these patients are, it's not stopping. So benefits for the sleep care team. We provide communication, as mentioned before, between the doctor, the patient, the DME, all these different go-to places. The patient is sometimes confused as to who to call for this question, who to call for billing here, who to call. So the sleep coach is this person that's just uniquely equipped with what this process looks like, where patients aren't equipped with what the process looks like. They have all these questions. And so sleep coach is there to be a support there, but also in the sleep center, if you can imagine being able to help in the success and the monitoring of your own patients, right now that's left in the hands of the DME. Most of the times the durable medical equipment is doing the monitoring, and it's specifically for these insurance purposes. DMEs kind of get a bad rap too. I like to think that they're trying their best. Some DMEs are just not equipped with a clinician. Sometimes it is a customer service rep that's really just trying to do the best they can at their job. But if you can imagine having a sleep tech or having a respiratory therapist, having somebody who is passionate about and understanding of what CPAP is like and just the whole clinical side of it, can you imagine how much different therapy monitoring would be, reaching out to that patient would be. I can only imagine it being done just a little bit differently and maybe a little bit more care and passion oriented. So better patient satisfaction in that. Hopefully they don't feel like just a number, but it also keeps patients in your clinic. Until this point, there's not really been any kind of reimbursement for this though. I know as a sleep tech, I was trying to monitor sleep or CPAP therapy, but it was really just put on the back burner because I was focused on all the other administrative duties. That was just not something that was reimbursed. So the DME company also benefits from having a sleep coach on board because if there are timely interventions and patients are being adherent to their machine, their devices aren't being returned. They're also using their equipment, so they're using the resupply option and they're getting new pieces, new masks, new tubing, new filters, and so there's downstream revenue and benefit for the DME company. The primary care, they kind of get left out of this process a lot of the time, but really in a lot of these value-based care systems, how cool would it be for them to know that their patient had a sleep coach that educated them on their sleep apnea diagnosis, but also how it related to their other health problems like high blood pressure, diabetes, and help controlling all of those other issues. I'm going to go through a couple other patient cases and we'll finish up. I'm going to talk about John. John, he had a severe sleep apnea diagnosis. He had typical symptoms: snoring, fatigue, witness apnea, poor sleep affecting his quality of life. He starts on CPAP usage, and as you can tell, he starts off pretty good. And then with these more red and empty spaces coming into the picture, he starts to struggle a little bit. So at a 30-day check-in with the sleep coach, we learn that his 63% compliance, we talk about just why he's not using his machine, what that looks like, what his numbers look like. A month or two before he had his sleep study, he was diagnosed with a completely different doctor as a different neurologist with cluster headaches. And come to find out, he, on all these nights where you see low usage or no usage, he was choosing between his two therapy options. He would actually take his CPAP off, go sleep in his spare bedroom so that he could sleep with an oxygen concentrator to help with these cluster headaches. So something just as simple as that comes up in these early conversations with the sleep coach, where the sleep coach says, hey, we have a solution. Let me talk to your doctor, reach out, submit a case. The doctor can approve and submit an order for an inline connector, and that person doesn't have to choose between two therapies, but they can benefit from both as needed. So at 90 days, after a few different check-ins in the middle, he goes from 63% to 83% compliant. And actually, the good news is his cluster headaches started going away, which was really a huge benefit. Okay, so Amy didn't have a severe sleep apnea diagnosis. Hers was more mild with an AHI of 6.1. Her lowest oxygen levels, though, were 80%. Her main complaint was high blood pressure. She was getting very anxious and stressed about the high blood pressure, which wasn't making that progress any better. Being told you have mild sleep apnea, a lot of people don't fully understand still how that relates to their issues that they're having. But to be able to go over with her what this means, what these oxygen levels mean, even though this AHI is mild, this is all still affecting your body negatively, and this is how you can benefit. She and I spoke on day 11, and she was overwhelmed. She was irritated. She was frustrated. She was like, I don't know how anybody can sleep with this machine. I can't use it for over an hour. She was given an auto CPAP of 5 to 15 after having a home sleep test. I was able to communicate with the doctor, hey, this is what's happening. These are her current settings. Her complaints are pressure. Is there a way we can reduce this pressure? And so the doctor sends in an order for reduction of pressure. I get a chance to check in a couple of days later. There's been no pressure change, so she's still frustrated, but she's needed somebody to reach out to, somebody to talk to, somebody to hear her. I know this is kind of cliche, but a lot of people don't care what you know until they know how much you care. They don't care how much you know until they know how much you care. Make sure I said that right. But I was able to check in and follow up with her, let her know she wasn't being forgotten, that those pressures are going to change. So about 10 days later, she saw a pressure change. We had a conversation, and you start to see her usage go up 18%. We got a chance to talk about cleaning and all her questions there, her different mask concerns. And then day 30, her compliance is 27%. But as you can see, it's increasing. She's just needed encouragement. She's needed reassurance. And she actually said, if it wasn't for your intervention, I would have given up already. So we fast forward to day 60. We have a check-in call with her. She's met that 70% compliance, but she still has a little bit of issues. She still is struggling. So she wants pressures reduced more if possible. They still feel a little bit high. And so that was another case that was able to be presented to the doctor before this 90-day follow-up. She was able to go ahead and schedule the physician follow-up. I was able to remind her of that, and then also remind her of the resupply program so that she can continue getting new equipment that works and that doesn't cause more issues by getting old and worn out. So at day 90, she's telling me her blood pressure is controlled, her usage is at 80% per CMS guidelines. She's even said her skin looks better. So it's amazing all the good things that you can see when you start sleeping better. And you guys know that. Sleep is healing. Her experience at this point has been positive, and that's a complete 180 to how she started. And all she needed was support. So the big question is, who pays for sleep coaching? I know I mentioned before, if you are in a non-clinical setting, it's different. You have clients that are more of a self-pay option. You have a business or more of an independent contractor. Whereas a clinical setting, I've mentioned this already, but in the DME, there's more of this downstream revenue. There's benefits from improving adherence for the patient, and for the company that provides the equipment. So future of remote patient monitoring. This is really exciting for me. This is something that as a day tech, when I was trying to monitor patients and I wasn't able to get what I needed, I wasn't able to do it effectively or efficiently because I just didn't have the time or resources to do it. It was really discouraging. So the idea of insurance now finally paying attention to the importance of paying attention to outcomes, it's exciting. I'm going to go into remote patient monitoring just briefly here, just to kind of give an update for those of you who may not know much about it. I do have another poll though, Rachel.
8%, yes, we've been billing RTM for more than a year. 3%, we've recently started billing. 32%, no, but we are planning to start. And 58%, no plans to do this.
Thank y'all for your feedback. Thank you, Rachel, for reading that. I appreciate you. Okay, so I'm going to go into just a little bit of detail. I'm not an expert on this. I've learned a lot from collaborating with people who are doing this, and what I really have learned, excuse me, what I've really learned, I don't know if you all can hear thunder in the background, but it's storming here. There are not a lot of people who are really even aware that these are here, but there's also a lot of intimidation to get started. I have gotten this inspiration from Drew Copeland. I mentioned him earlier with Sleep Better NYC. He did a presentation for Philadelphia Sleep, and this was really, excuse me, this was really encouraging to me. So I wanted to share this too. So these codes are new. They were really sent out by CMS in 2019. And then you'll see like little terms here: general supervision, transition from direct supervision to general from 2019 to 2021. That just means this doesn't have to be done in the doctor's sleep or in the sleep doctor's office in that physical location. It can be done outside of that sleep doctor's office. It can be done by staff, but that the general physician is, or that the physician is supervising and they are looking over it and they are approving and they are involved in this, but they aren't doing the monitoring themselves. So remote patient monitoring can really be separated into these two categories. You have remote physiologic monitoring, remote therapeutic monitoring. So RPM is more physiologic data, whereas RTM is more therapy, like patient reported data they're benefiting from. But they share a lot of commonalities, and I'll go into detail here in just a little bit. But these are just very new, and they're very exciting because insurance is finally paying attention. Here are RPM, RTM codes, RPM, remote physiologic monitoring, and then remote therapeutic monitoring. They have different codes, and I'm just providing codes for you to pay attention to them as well. I'll give a little bit more detail, thank you, Rachel, into just an example. So I'm focusing specifically on these remote physiologic monitoring codes just because they've been around a little bit longer. The remote therapeutic monitoring codes are still very new, but those RPM codes, I'm giving just an estimated insurance reimbursement from what we've seen. And basically you've got one for just initial setup and education. The patient gets set up on their CPAP, for example, and you have somebody that goes over their AHI. They go over what the CPAP is doing, how this is monitoring, and give detail and give feedback and give at that point in that conversation, like, what is your why? There's just this initial setup of, hey, you're being enrolled at this program. We're wanting to just monitor and make sure your therapy is good and you're experiencing benefit from it. So there's a code with that, or there is reimbursement with that first code. We're seeing anywhere between $13 to $20. You have the 99454 code where it's per 30 days. You're monitoring actual data that comes in. You have to have at least 16 out of the 30 days of usage and data that has come in. But just monitoring this usage, you can see reimbursement anywhere from $30 to $65 for that. 99457, this is an actual conversation with the patient. The sleep coach or the clinician has a conversation with the patient. If you speak with that patient for 20 minutes just in one phone call, or if it's 10 minutes here, 12 minutes here, you're able to bill for that conversation 20 minutes. And that's billable in itself. But if you communicate with that patient even more throughout the month and you reach up to 60 minutes of conversation, each of those 20 minutes is billable with another code. So for an example, you have somebody that gets set up on a CPAP and you monitor their data and you communicate with them. That's $150 for that one patient. And if you just think about scaling that, that number can grow and those patients benefit. So why do we do what we do? We want people to heal. We want people to sleep better. And based on the statistics, we've got a lot of opportunity to help a lot of people. So the sleep coach is a safe place for the patient. It's an educated advocate for the patient and the care team. And it's this glue that holds this really bumpy and disconnected and fragmented and stressful path, makes it a little bit more smooth and whole. So whatever you are, be a good one, whether it's a scheduler, if you're a mentor to the new techs coming into this program or into our field, and whatever that may be, take pride in what you do. You are important. Our patients need you as a human and as a clinician to be a part of their journey. So thank you. Do we have any questions?
Thank you. We did have one more poll. Would you like me to launch that a minute?
Yes, we just talked about that. Sorry about that.
That's okay. I will launch it right now. So last poll here, everyone. So 18% biggest obstacle to starting a sleep coaching or RPM program, someone to take the lead. 29% sleep tech or other staff to manage it. Other is the biggest, 46%, and not a priority is 6%. If you did indicate other, at the end of the webinar, when we have the survey, there is like the last question. It's not related to this, but if you want to tell us what that other obstacle is, we'd love to know. So you could just throw that into the survey at that point. All right. Okay, so now we get to introduce our panelists. So Andrea and Mark, if you two could come on camera, great. So Andrea Ramberg is EnsoData's clinical director, and she's going to facilitate the questions. And Mark Kaiser is EnsoData's VP of Business Development and Partnerships. So he'll collaborate with Lacey on providing answers to the questions. So go ahead, Andrea, I'll let you take it from here.
Thank you, Rachel. So Lacey, I know you covered this in your presentation of how do we justify the cost of a coach when insurance doesn't cover it. And I was hoping to maybe provide a little bit more of an explanation with that. You gave us some great examples, but I'd like to think more of a mindset shift is needed in our sleep field and medicine general, right? Like we are seeing this shift in text roles happen. We are seeing this change of technology, all of that stuff. So that is bringing about this need for these sleep coaches, sleep navigators, all that other thing. And we are focused now on much more outcomes based. So if you look at trying to justify these type of roles, it's almost like speaking the language of what those outcome-based savings will create. EnsoData recently did a research process that actually showed that roughly 20% of Medicare patients were much more compliant, had their much reduction of costs at the end of 12 months if they were compliant with their CPAP. So we need those numbers to better be able to prove these. Once we have those numbers, then we have the insurance companies listening, I think, and making sure that that shift in mindset. Mark, is there anything you'd like to add to that?
Just a reinforcing of what Lacey shared. The RPM and RTM codes are still relatively new, and especially the provider community is kind of learning and testing. How do you utilize those codes? What qualifies for those codes? And perhaps more importantly is really the operational and staffing and other things that are necessary to kind of basically stand up a new program. We know that if a sleep tech is going to be a contributor to that role, that there's a challenge with sleep tech staffing really nationwide here. And so that can be a primary challenge to being able to kind of even perform these programs, but then also to satisfy the documentation or the other requirements necessary to bill for them. So, but luckily we do have some of these new reimbursement schemes in place for providers to be able to kind of justify the operational expenses.
Thanks, Mark. Another question. I need formal education to learn. What pathway do you recommend I take to achieve my CCSH? And so there, as Lacey did, there's multiple pathways to take, and there are now a bunch of different programs that are coming out to actually give you that formal education. I know Collins College has a great CCSH education. AST and the ASM both have great education content if you need that formal education learning, which I would highly recommend it. If you don't have that bachelor's associate's degree, there is now pathway 3 that you could take as long as you've been in RPSGT for 5 years, and then you take one of those formal education processes, and then you'll be able to be well on your way to join the crew.
All right, thank you, everyone. Lacey, that was fantastic. I just love how passionate you are about helping people. If you want to learn more about EnsoSleep, if you want to free up some time to start sleep coaching or an RPM program, just go ahead and explore our website, or you can reach out to us again at team@ensodata.com. Thank you so much for attending this webinar today. We really appreciate the opportunity to provide educational topics for the sleep community. And of course, we appreciate everything that you do and all the important work you're doing for your patients. So thanks again and have a wonderful day.
Thank you.